Dr. Renmai Soman. Dr. Pliskanovskaya Svetlana sent her video presentation to you. So firstly, we should watch this presentation. After that, if you have any questions, please write in the chat or just tell me your, you may ask your questions also. Thank you very much.
Dear Congress Organizing Committee, thank you for the invitation to participate in this Congress work. Dear colleagues, let me to present your report named Specifically Sensitized Leukocytes Role in Children Brain Disorders, Pathogenesis. Diseases affecting the nervous system are diverse and include nervous system development disorders, late age-related changes, neurodegeneration, and cognitive environment of the infection. Total neurological loss adjusts for year on disability increased on 18%. The role of immune system and neurological pathology remain yet unclear. There is a relevance of research aimed at the elaboration of the new biological markers of brain damage and nervous system diseases, especially in pediatrics. The introduction of CNN pathology diagnostic and treatment would lead us the new diagnostic and treatment strategies development. The purpose of our investigation was to determine the circulating leukocytes sensitization degree to some brain tissue soluble antigens and the possibility of the obtained results using as a children brain disorders predictors. The 50 practically healthy children, 20 children with epilepsy and 15 children with autism who were under observation in the neurological center of the Ashgabat, Turkmenistan, were examined. In both practically healthy and patient in addition to a special clinical and instrumental examination of the brain, the degree of the peripheral blood leukocyte sensitivity on brain tissues antigens was determined. The degree of sensitization of leukocytes to antigens was determined in a modified reaction of leukocytes migration inhibition. The results were expressed as the leukocytes migration indexes. Tissue-soluble antigens of the hippocampus, substantia nigra, anterior temporalis, lobe osula, and substantia alba have been used as a migration inducer. The obtained results were mathematically processed using the SPSS program USA. Result. The study showed that the peripheral blood of the both healthy children and those with autism and epilepsy circulating leukocytes sensitive to tissue antigens of some brain compartments. There are hippocampus, substantia nigra, anterior temporalis lobe, insula, and substantia alba. The diagram shows that each of the diagram shows that the pathologist who studied has an own sensitization profile. For example, autism is characterized by the increasing of the leukocyte sensitization to the anterior temporalis lobe and the substantia alba. Epilepsy is characterized by the increase of the leukocyte sensitivity to the substantia nigra, anterior temporalis lobe and substantia alba. As can be seen from the diagram, in healthy children, leukocytes migration index value are independent of the type of antigen and range from 50 to 75. Ну где же, никак не дает там. The response to the hippocampal antigen remains unchanged, depending on the diagnostic and range from 50 to 55. The difference is not mathematically significant. However, in children with autism, the response of the substantia alba and anterior temporalis lobe antigens is significantly increased to compare the healthy persons, and leukocytes migration indexes value reach 80, 98, 120 respectively. The maximum response to the antigens anterior temporalis lobe, substantia nigra, and substantia alba expressed in children with epilepsy, as can you see. Epilepsy is there, and healthy children. Certainly, further studies are needed, covering a large number of different ages and genders children, and well as the other brain compartment and antigen preparing. Wait, needed. Conclusion. Elaborated terminological method for determining autoimmune damage of central children's brain compartments degree allows, in our opinion, to assess the functional activity of these compartments. This method allows to identify the cause of the children's developmental delay and carry out early preclinical and predictive diagnostic of brain pathology. Thank you very much for your attention.
My presentation is here now. Does it appear? Hello?
Yeah, hello. Yeah, it's seen.
Okay, thank you. Thank you, the organizing committee, for give us the chance to present in this symposium. I am Dr. Tasneem Nubayed, the consultant in pediatric infectious disease, Saudi Arabia. I will present now my article that published on 23 April 2025. Sorry, my voice is clear?
Yes, doctor.
Yes, okay. The topic that's the article about it is knowledge, attitude, and practice of Saudi parent regarding antibiotic use for children, cross-sectional study. This is the journal that we publish on it. This is the website for it. It is International Journal of Pediatric and Adolescent Medicine, and this is the number that you can check on it. Background. Raising awareness about the proper use of antibiotics is crucial, as misuse can lead to significant side effects and antibiotic resistance, similar to challenges faced on chemotherapy treatments. Material and methods. The number of subjects is 356 individuals. Inclusion criteria, Saudi parents. Exclusion criteria, non-Saudi parents. Research design. This cross-sectional study employed a sample size of 356 participants, determined use using an online sample size calculator via Google Forms. Minimization of risk. No identifiable information will be collected to ensure confidentiality. Anticipated benefits. No direct benefits for participants. Data collection method collected directly from the subjects. The questionnaire given, including demographic data and the questionnaire for the topic. For the demographic data, parent age distribution number, most of them between 31 and 40 age group. Level of education, most of them college level of education. And for parent employment status, most of them employed, and there is percentage not employed, and this is common in our country for the women's. As several mothers, we have as a housewife in our culture. Among those employed, 28% work in healthcare. Household monthly income, most of them between 10,000 to 20,000 Saudi Riyal. Frequency of having health insurance, 61.9, they are having health insurance. Now we'll come to the questionnaire for the topic itself. We give questions. Antibiotics effectiveness decrease if the full course was not completed. 44.7% strongly agree and 43.8 agree, which is a good percentage. It's about 85. That is, they are aware that is that if not complete the course, that antibiotic effectiveness. But the other question, I prefer stopping antibiotic as soon as the symptom improved. Unfortunately, 75% agree about this statement that they can stop the antibiotic once the symptom improves. Giving unnecessary antibiotics decrease their effect and lead to bacteria resistant. About 40% disagree and about 36% agree. So more than 70% aware that giving unnecessary antibiotic decreases their effectiveness and lead to resistance. But antibiotics don't cause negative effect. Most of them, which is 36.7, disagree about this statements. That is, antibiotics don't cause negative effect. A child with a cold or flu will recover quickly if given regular doses of antibiotic. Unfortunately, about 45% can be treated by antibiotic even for flu. They don't know is it viral or bacteria. Did you give your child antibiotic without a prescription due to time constraints or lack of money or medical advice? 70.7 rarely. So this is good percentage, but this is supported by our culture and our rules as antibiotic not prescribed without prescription of physician. I will ask the pediatrician if my child really needs the antibiotic when it's prescribed. So there is good percentage here as 51.2 always will do that. The pediatrician prescribed antibiotic over the phone, rarely 71.8%, which is expected because our rules in our country that have restriction of the prescription of antibiotic only for needed patient. I will express my agreement to my pediatrician if they prefer not to prescribe antibiotics. The good percentage, which is 47.4, always they will do that. Do you believe that antibiotics are being overused? Good percentage, which is more than 50%, including agree and strongly agree. They are aware or believe that antibiotics are overused. Antibiotic should be given in case of high fever, regardless of the cause. Strongly disagree, which is 40.5%, but unfortunately still there is some percentage they have thinking that the fever can be treated by antibiotic. Viral infection could be treated using antibiotic. 26.8% agree about that, and 10% strongly agree. So more than 30% they are thinking that viral infection can be treated using antibiotic. Antibiotics are effective against bacterial infection. Agree 43 and 26% strongly agree, but unfortunately still some population, some parents doesn't know the antibiotic why we give it for the patient. Did you give your child an antibiotic without prescription based on recommendation from friends or family? Rarely, 77.5%. And this is expected because of our rule in the country that avoid prescription without physician prescription. Do you give your child an antibiotic without a prescription because their condition is not serious enough to see a pediatrician? Rarely, 69%, and this is good condition that is good thing that they will not use antibiotic empirically. Scientists can create new antibiotics to tackle resistant bacteria. Unfortunately, about 50%, including the agree and strongly agree, they are thinking that still we are producing a new antibiotic for resistant bacteria. So now this is the result. We'll come to discussion of this result. Awarenesses of antibiotic overuse is generally high among parents, showing the impact of public health efforts. However, some groups remain natural or unaware, highlighting a need for continued education. Most parents act responsibly in antibiotic use, indicating positive behavior trends. Financial and time limitations still hinder responsible healthcare access for some families. Around 75% of participants recognize the side effects of antibiotics. The remaining 25% require targeted education, antibiotic safety, and misuse risk. Pediatricians are the main source of guidance for most parents, reflecting a trust in professionals. Some parents' infrequent consultations suggest possible self-diagnosis or underestimation of professional advice, while many follow pediatrician recommendations. Hesitancy persists in a minority due to misconceptions. The rare use of over-the-phone prescription are uncommon, indicating appropriate healthcare practices. Strong parental focus on health is evident, but the natural and disagree responses could indicate parents underestimating their health management responsibilities. While most parents prioritizing professional healthcare, a segment still avoids this consultation, possibly due to financial, time, or accessibility barriers. Parents expect a balanced approach to antibiotic prescription, valuing pediatricians who neither overprescribe nor withhold antibiotics unnecessary. So, based in this result and discussion, our recommendations, educational programs should target both parents and healthcare professionals to improve antibiotic knowledge and practices. Behavioral campaigns can promote completing prescribed antibiotic courses and avoiding use for viral illnesses. General education alone is insufficient. Healthcare-specific and targeted awarenesses initiatives are needed. Community and school-based education can enhance parental understanding of appropriate antibiotic use. Collaboration among pediatricians pharmacists, and educators ensure consistent public health messaging. Focused interventions are required to reach lower income and diseducated populations. Encouraging responsible antibiotic behavior, support infection control, and reduce resistance. Combining education, accessibility, and behavioral change will strengthen rational antibiotic use in the community. Develop target education program for those who are natural or incorrect about antibiotic use. Focus on the importance of completing antibiotic courses. Provide clear information about antibiotic side effects and resistance. Consider gender-specific education approach. And other recommendations focus future research on other potential factors, healthcare accessibility, cultural beliefs that may contribute to antibiotic misuse, especially for the mother who are the most care for the children in the home. Thank you, and see you in other presentation.
In the beginning, I want to thank organizers for inviting me to present this talk on holistic psychosomatic nature of bioenergy correction at your webinar of International Conference of Pediatrics and Neonatal Care in November 2025 in Paris, which was also presented previously in Prenatal Science Global Congress, Prenatal Sciences Partnership, online in 2022, and which is published as a paper in International Journal of Prenatal and Life Sciences in November 2022. I am Professor Dejan Rakovic. I'm coming from the Faculty of Electrical Engineering, University of Belgrade, Serbia, as a retired professor. I'm also related to two another institutions, Life Activities Advancement Institute in Belgrade, Serbia, where I have mutual scientific project with them, and Whole Self-Discovery and Development Institute International, where I'm co-director for Serbia. Also, I would like to pay your attention to my two websites, www.dejanrakovic.com and www.dejanrakovicfund.org, with many information about my scientific research, with many publications and so forth. And also on this slide I would like to mention a motto of Bruno Gröning, the greatest healer of the 20th century: I live that humanity could still live. On this introductory slide is mentioned that bioenergy correction is correction of flow of vital energy, known in many traditions for millennia, with some model modifications, on the expansion of integrative medicine since mid-1990s in China, United States and Europe. Some bioenergy correction techniques were subjected to scientific research and included in local medical curricula. Our biophysical studies of consciousness and psychosomatics also point to real nature of holistic experiences of traditions of East and West, implying that quantum holographic fractal hierarchical paths carry information on holiness, like Hindu relationship Brahman-Atman, enabling subtle quantum holographic coupling of hierarchical levels in nature. This is indicated by acupuncture system and its projection zones, like modern holographic concept in Chinese medicine, discovery of quantum holographic influence on genome expression in speech modulation of electromagnetic laser signal, transpersonal origin of incredible creativity of Tesla and Mozart as case studies, and predestined life paths and temptations suggested by experiences from hypnoregressions and tribal traditions and traditions of East and West, emphasizing that they can nevertheless be optimized by spiritual purification. These traditional concepts are also supported by holographic principles that teach three-dimensional physical system is isomorphic to holographic information imprinted on its two-dimensional surface, implying that quantum content of three-dimensional body could be holographically contained in body's two-dimensional surface layer, which is in line with our quantum holographic quantum gravity theoretical framework of consciousness and psychosomatics, and supposed close relationship of acupuncture system and consciousness, supported by meridian psychoenergy therapies as well. Biophysical research of integrative medicine and transpersonal psychology is of special importance due to widespread usage in developed countries, as contemporary investigations of stress-induced psychosomatic diseases suggest necessity of holistic methods, focusing on the acupuncture system and consciousness, oriented to treating man as a whole, suggesting their macroscopic quantum origin, with significant global implications. So it may be said that there are three front lines of psychosomatic quantum holographic integrative medicine. The first one, spirituality and circular psychoenergy therapies from all relevant metapositions, with permanent removal of mutual quantum memory attractors, states, on the level of collective consciousness, due to energy informational disentanglement of mental addresses of all persons involved in the problem. The second line, quantum holistic medicine and non-circular psychoenergy therapies, which temporarily remove memory attractors on the level of the acupuncture system, individual consciousness, and prevent or alleviate their somatization as a result of negligence on the first front line. And third line, symptomatic conventional medicine, which via immunology, pharmacology, biomedical diagnostics and surgery on somatic level prevents or alleviates consequences of carelessness on the first two front lines. It should be particularly noted that the necessary activities in the second and third front lines, with neglect of the first one, would result in further transfer of memory attractors on the level of individual and collective consciousness in this and future generations, thus accumulating quantum holographic non-local loads that cause not only diseases but also interpersonal conflicts, wars, and other sufferings. Further on, three aspects of the acupuncture system, consciousness, and vital energy should be pointed out. The first one, quasi-classical ionic aspect of the acupuncture system, suggested by research of the non-threshold gap junction electrical synapses, presented in figures 1 to 3 in appendix, which have shown an order of magnitude increased concentration at the acupuncture points that is consistent with the much lower electrical resistance of the acupuncture points compared to their surrounding tissue, as well as a significantly higher absorption of the air ions in these points. The second one, quantum informational electromagnetic aspect of the acupuncture system, indicated by quantum coherent characteristics of Russian-Ukrainian School of Microwave Resonance Therapy, and discovery that any quantum system has formal mathematical structure of Hopfield quantum holographic associative neural network, presented in figures 4 and 5 in appendix. It is also pointed out that the acupuncture system is at least psychosomatically related to consciousness, as supported by very effective meridian psychoenergy therapies with successive setting new boundary conditions in the acupuncture system during emotionally involved visualizations of psychosomatic problem. And third, transpersonal exotic aspect of energy informational communications, known in all traditions and now widely used in transpersonal energy therapies such as Qigong, Reiki, pranic healing, through established and stabilized energy informational channels of vital energy, Qi Prana, pointing to a deeper exotic space-time nature of these channels of vital energy. IDEST connection with exotic quantum vacuum fluctuations necessary for anti-gravitational stabilization of these space-time channels. See also figure 6 in appendix. So it seems that joint research on the crossroad of psychosomatic integrative medicine and quantum informatics may become fruitful in spreading frontiers of the existing scientific paradigm. It should be also noted that healing effects on patients' acupuncture system and consciousness are often blocked by quantum holographically encoded spiritual personal consent to disease as a form of self-punishment, as evidenced by subject experiences in post-hypnotic regressions, when prayers and self-love for oneself and others are necessary with aim of ending self-punishment, thus performing spiritual integration of personality, disentanglement of transpersonal energy blockages, which initiates process of permanent healing. Such spiritual indeterministic interventions by introducing new vacuum excitations of vital energy in otherwise deterministic quantum holographic evolution of collective consciousness, similar to spiritually excited and mentally channeled Ayurvedic, Qigong, Reiki, and modern experiences of local and transpersonal healings, thus non-Schrödingerian imposing necessary essentially new boundary conditions, can permanently remove as net effect whole mutual conflict between two persons, which is also greatest source of freedom in optimizing life programs by spiritual cleansing. In particular, let us mention Hawaiian Ho'oponopono tradition with great reprogramming of life situations by contextual repentance and forgiveness to oneself, or South American ayahuasca tradition, or Nigerian Abiko tradition, with incredible spiritual diagnosis and extensions of predestined short life programs, or fascinating Anita Murjani bestseller on spiritual change in her life programs by returning from clinical death and after weeks of spontaneous healing from terminal phase of cancer, or contemporary spiritual teaching of Bruno Gröning with incredible healing channel that remained open even after his death in optimizing both individual and collective life programs, or traditional Christian Hesychastic mysticism with miraculous healing and optimizing life programs. This significantly contributes to our understanding that even most severe psychosomatic disorders have their roots in energy information blockages, and that healing begins by removing them, first by loving oneself, accepting oneself, and forgiving oneself, which is then manifested by loving others and accepting others, or spiritually disentangling, unleashing, repentant, forgiving prayer. It should be concluded that transpersonally extended esoteric concepts of spiritual traditions of East and West could be biophysically counted within our plausibly extended quantum holographic quantum gravitational theoretical framework. Astral body, known as Mano Maya, Linga Sharira, Manovijnana, Ka, Psyche, Nefesh, Nefs, subtle body, psychic body, soul in different traditions, versus ionic component of electromagnetic ionic exotic macroquantum acupuncture system displaceable out of body. In our model, connected with body by miniature wormhole space-time tunnel generated in highly non-inertial transitional states of consciousness as reported in extrasensory near-death experiences. The second, mental body, known as Vijnana Maya, Suksma Sarira, Manas, Ba, Timos, Ruach, Ruch, noetic body, spiritual body, mind in various traditions, versus electromagnetic component of electromagnetic ionic exotic macroquantum acupuncture system displaceable out of body in our model, embedded with ionic component of acupuncture system, within ionic component of acupuncture system. Third, distributed centers of consciousness, chakras, acupuncture points, sephiroths, holy discs known in different traditions, versus electromagnetic ionic condensates of electromagnetic ionic exotic macroquantum acupuncture system displaceable out of body in our model. And fourth, vital energy, known as chi, ki, prana, akasha, mana, ka, pneuma, ether, natura medica, anima mundi, yesod, baraka, uncreated light, Holy Spirit, Harstrom, innate intelligence, bioenergy, biofield, versus electromagnetic ionic exotic condensates detectable within electromagnetic ionic exotic macroquantum acupuncture channels detectable out of body and non-detectable outside them within our model, with possible generalization from electromagnetic field to unified field in line with broader traditional meaning of vital energy as all-pervasive cosmic quintessence. And on this slide is presented the content of our Symposium of Quantum Information Medicine in 2011, acupuncture-based and consciousness-based holistic approaches and techniques, organized in Belgrade in September 2011, with topics on holistic medicine and non-circular psychoenergy, therapies for balancing acupuncture system and individual consciousness, in particular traditional acupuncture simulations, acupuncture, moxibustion, acupressure, microwave resonance therapy, bioresonant diagnostics and therapy, laser puncture, magnetotherapy, segmental reflex massage, lithotherapy, chiropractic, homeopathy, chromotherapy, aromatherapy, air ionization, yoga breathing, meditation, autogenic training, psychotherapies. And second group of methods, spirituality and circular psychoenergy therapies from all relevant meta positions for balancing individual and collective consciousness, like prayers, Ho'oponopono, transpersonal psychotherapies, family constellations, meridian therapies, Qigong, Reiki, reconnection, Theta, shamanistic traditions. And final comment, our quantum holographic quantum gravitational theoretical framework of consciousness and psychosomatics, in line with increased scientific interest for consciousness in past decades, anticipates great synthesis of two modes of knowledge, rational scientific, classically reduced in normal states of consciousness, and creative, religious, quantum entangled in transition and altered states of consciousness. Thus, the role of every individual might become irreplaceable due to influence and care for collective mental environment, leaving more space for free will. This would point to full significance of holistic education and behavior, demonstrating necessity for redefining global educational, informational, political goals, with reorientation towards holistic, gentle actions for solutions of global risk society. The decisive role in this process could be played by all religious communities and transpersonal spiritual practices, cultivating true spiritual, moral, and absolute interpersonal, interethnic, and interreligious tolerance as measure of individual behavior from perspective of death. It is amount of generated and non-reprogrammed psychosomatic conflicts until death, which determine spiritual evolution of soul of diseased, as well as preferences of individual and or collective future of descendants that can be significantly altered only by a collective prayer for our neighbors and enemies, and thus global reprogramming of collective consciousness. This is a slide with my reference list. And at last, I have 2 slides about my CV, short CV. I graduated at Faculty of Electrical Engineering in 1974. Then I got Master of Science thesis in 1977 and PhD thesis in 1982 from the Faculty of Science in Belgrade, Physics Division. Then I got my position at the Faculty of Electrical Engineering in Belgrade in 1977, where I became full professor in 1997, where I taught numerous courses until my retirement in 2016 in material science, biophysics, biomaterials, quantum information, and doctoral group of courses in non-medicine, where I also headed Department of Material Science in several election periods, undergraduate module of physical electronics, postgraduate material science curriculum, and undergraduate biomedical and ecological engineering curriculum. Since 1995, I was co-founder and vice president-elect of Yugoslav Materials Research Society with numerous activities in past 25 years. I also headed Brain and Consciousness Regional Project of European Center for Peace and Development, ECPD, of the United Nations University of Peace in Belgrade, where we edited several books on consciousness studies. Also, I headed ECPD, International School of Quantum Information Medicine, from 1999, with co-authored textbook Introduction to Quantum Information Medicine with basics of quantum holographic psychosomatics, acupuncturology, and reflexotherapy in 29 in Serbian. In 1999, I also co-founded International Anti-Stress Center in Belgrade, becoming president-elect of this center, with wide educational holistic anti-stress activities, in particular with co-authored Anti-Stress Holistic Handbook, with fundamentals of acupuncture, microwave therapy, relaxation massage, ionotherapy, autogenic training, and consciousness in 1999 in Serbian. Proceedings of Science and Religion Society, 2002 in Serbian. Proceeding Religion and Epistemology, 2005 in Serbian. Textbook Fundamentals of Biophysics, 3rd edition in 28 in Serbian. Scientific popular book Recollection Dreams, Thoughts About Past and Future. On crossfade of quantum holographic and classically reduced reality in 28 in Serbian. And monograph Integrative Biophysics, Quantum Medicine, and Quantum Holographic Informatics, Psychosomatic Cognitive Implications in 2009. In 2009, I also founded my fund for holistic research and ecology of consciousness with wider promotive holistic activities, including proceedings of mentioned symposium and roundtable of quantum information medicine, acupuncture-based and consciousness-based holistic approaches and techniques in 2011, proceedings of first Congress on psychological trauma, prenatal, perinatal, and postnatal aspects in 2015, and book Prenatal Psychology 100 Years, A Journey in Decoded, How Our Prenatal Experience Shapes Who We Become in 2011, becoming Whole Self Co-Director for Serbia. Be well, and thank you for your attention.
Thank you. That was a great presentation. I hope everyone's learned something new. I want to ask if anyone has any questions for Doctor.
Well, thank you for your attention. I can reply by chat afterward. Thank you again for inviting me to present this talk.
I hope you see my information. Yes. And yes. Okay.
Yes, it's visible.
Yes, my name is Larisa Kalashnikova. I am from Ukraine, and now today I want to present our scientific research about musical effect to psychosomatic mechanism for regulation of external respiration function in children with bronchial asthma. An integrated approach that includes both medicine and alternative methods that affect the psycho-emotion state of the patient in this problem, and used for bronchial asthma treatment in this regard. One of the methods of the most powerful psycho-emotion impact on person in the musical influence. Research of the influence of audio signal as musical fragments on the human body in order to improve the psycho-emotion status of the listeners began to be systematically undertaken since 1912, use the guidance of Professor Vitaly Dyskovsky and me at the Department of Acoustics and Electronic System of the National Technical University of Ukraine, Igor Sikorsky, Kyiv Polytechnic Institute. Joined with the Department of Respiratory Disease and Respiratory Allergy in Children of the Institute of Pediatrics of the National Academy of Medical Science of Ukraine under the guidance of the Dr. Sergei Bartyn. These special symptoms symptoms bronchial asthma as psycho-emotion status is very important for children with this pathology. And as we know, children have this syndrome, psycho-emotional syndrome, and pathological process of asthma involved nervous, endocrine, and immune system, which integrates the vital process of the body. And sufficiently on the organs mechanism of oscillation and bronchial asthma resistant, because predisposition for realization of central pathology influence, impaired function of the central nervous system in patients with asthma are notable during acceleration and post-attacks period. Therefore, the integrated approach includes drug and methods that affect psycho-emotion state of the patient is used in asthma treatment. The symptoms worsen the course of the underlying disease and associated with higher rate of hospitalization and worsening of control of asthma manifestation and signification after the quality of life and ability to work and social activity of patient. The novelty of our research lies in the fact that we study the effect of musical influence only its physical character, frequency, amplitudes, and ultimately from energy of the musical wave, which was calculated by an original program developed at the Department of Acoustic and Multimedia Electronic System. Previously, as a therapeutic method, music was used to sign or play musical composition by playing wind instruments with the aim of training the muscle that are responsible for the functioning of the respiration system. Music wasn't used to influence the psychological status of children with asthma. And this our idea create objective our work. Objective our work of these we think that study the effect musical composition with different amplitudes range audio status to mechanism ventilation respiration regulation system children with asthma. Materials and method our work maybe one moment. Maybe 20, what we do. At the first, in our work, present children, 25 children aged from 90 to 15 years with clinical established bronchial asthma participated in the research. The researchers worked carried out using well-known standard diagnostics method, spirography and electroencephalography as standard method in clinics, and this method was used. There are three melodies of different components composition were used too. The amplitude frequency characters were analyzing by MATLAB environment. The source energy fraction of the study musical composition in this octavia frequency bands through the duration of the audio signal was our calculation. This inform some you can see on my post. Please spirography method and electroencephalography method. And next we use music, three frequency amplitude character, and use special structure for enter music signal inner here, and you see on this table character by frequency, but in our work we characterized our music by energy wave, because very hard find that special frequency and amplitude characters that we can see in one melodies, all different form, and for unical our signal and parameter our signal, we use energy wave, and results our work you see on this graph. if you understand my speech, sorry, because today we have very hard day in Kiev by electricity. Okay. And next, we analyze it, energy wave by a special original program in environment MATLAB. The second energy fraction of the studies, musical composition, and all this was calculated. And what may be next? As a result, our work, what may be? All our work we can divide, sorry, we can divide to range. The first study, we sorry, I have electricity problem now. One moment. I transform my electricity position. Sorry. One moment. Okay. I turn off, turn on, and now it's good. And as I tell, we have two stages. The initial is the musical influence on the indicator of electrical activity of the brain was studied, and namely the energy of the brain rhythms, alpha, beta, delta, and theta rhythms, in the relation of the background electroencephalograph waves when listened to the study's audio signals. The results of this series of studies are presented in table, and you see this table as a blue table, please. We use all, in this table, we use all children that present in hospital, pediatrics hospital. At the second stage, the specify of the musical impact on children with the bronchopulmonary pathology were studied. At this stage of the researcher, audio fragment 3 was used as a factor of musical influence and demonstrated the greatest efficiency in normalization ventilation parameters. And finally, as conclusion, please, what I want to tell some words about our great results. You can read all in my post, please, from one side, and other side, please, some words. The study results demonstrated reliable normalization of spirography indicators in children with bronchial asthma under the influence of the selected musical melodies of a specific frequency. The most effective normalization of respiratory function in children with bronchial asthma was achieved by listening to musical fragment 3, a fragment as Mozart, the Magic Flute. The fragment contains sound signals with a predominance of low and mild frequencies. Listening to fragment 3 promotes change in the activity of the alpha and beta rhythms, but maybe not only activity, we can tell about activity alpha and beta rhythm. We can speak about balance between alpha and beta signal, our brain, and reduction in psychoemotion stress. This balance between alpha and beta activity according to stress balance, as we see by and normalization function, respiratory function, children with asthma. What is final words? The effectiveness of the sound influence on the central regulation mechanism on the bronchi ventilation capacity can be used for preventive and therapeutic purpose. We can use this method as add method in rehabilitation children with bronchial asthma in general and complex in general method therapy, or maybe as rehabilitation, as one of the method that include in rehabilitation complex for children with asthma. Our work is the first work, and we have only the first opinion in this way, and hope maybe we continue this work. But our very interesting, as we all, our group, researcher group, think very interesting information, science information have now, and we think that it's very important for therapy asthma, bronchial asthma in children. We work with children, and why children? Because children was affected by enter signal, pathology signal or stress signal, and answer this effect by very bad character internal function, respiratory function. And thanks for your attention. And I don't know that I must show my biography, but I can explain what I am. And if it's interesting, I can show. And one moment, I show. Or can one moment. What I am, please, is I, and you can see I have dress similar. Larissa Kalashnikova. I am PG in biophysics, associate professor, Deputy Dean International Affairs, Faculty of Biomedical Engineering, National Technics University of Ukraine. But together with other department, acoustics department, we and pulmonary department of pediatric clinics, we together work with this idea, because our idea is a novelty at the first. I note, because we read many information source in very interesting too, but we use only one parameters, acoustics wave. Initial parameters, acoustics wave, physical parameters, because all our signal that we can hear as physiological sound From other side is physical acoustics wave. And we use these parameters, amplitude and frequency, but classificate music by only frequency or amplitude unknown because it's impossible because very different indicators, and we use indicators that show all these parameters from different musical fragment as energy wave. And thanks for your attention. And maybe you have questions, not only for me as a scientific worker, and maybe you have, I repeat my сейчас одну минутку. Yeah. My post. I hope you see now, and what we can see in this my post. It's our conclusion, but idea conclusion I explain you, and you can see our results. According electrocortex brain, or other name is neocortex, or please table that show functional respiration system. Patient with bronchial asthma, and what I can add. We use not only the most important parameters in spirography as PHEV and PHEV1, but see parameters that show status of smooth muscle of small bronchi. And if you see other table, the best small bronchi show answer for musical effect, and it's very important because only I won't tell that only this, as I think, parameters support our idea, because asthma effect dependent from work this structure in bronchi tree. Thanks for your attention.
Colleges, we say me, call, we hear me, please. Correct.
Yeah, we can see you and hear you, doctor.
Oh. You may start. We talk about simultaneous hernioplasty in pediatric laparoscopic appendectomy. Laparoscopic appendectomy is the gold standard for treating children with acute appendicitis in all world. The incidence of this disease, 3-5 cases per 1,000 children. The number of children hospitalized for complicated appendicitis, local and diffuse peritonitis, also remains unchanged. It's abdominal pain and ultrasound picture about acute appendicitis, and the schematic picture in laparoscopic appendectomy. And not typical variant, because this picture used suturing apparatus for appendix. And we used laparoscopic surgery and laparoscopic appendectomy, laparoscopic revision of abdominal cavity. We see many intraoperative surprise, may cyst, functional cyst in girl, and maculum diverticulum, and inguinal hernia. For this topic, we used in two publications all internet. Is in Russian Federation. Authors Galamov say about simultaneous population, and next article about laparoscopic simultaneous inguinal hernia repair and appendectomy in children with ecology in China. Purpose this walk-in to present the experience of appendicitis combined with inguinal hernia during urgent laparoscopic in children. In this picture, we see intraoperative photo, laparoscopic abdominal for 80-year girl, and we see for this used 3 ports laparoscopic, traditional 3-port laparoscopic, 1 port in umbilicals, 10 millimeters, and 2 ports of laparoscopy in left region in abdomen for walk-in instruments. And we see picture in abdominal cavity. We see gangrenous appendicitis, inguinal hernia in these children. Sorry. We conducted a retrospective analysis of the medical cases of 30 patients. They were treated for acute appendicitis from 22 of the Kursk Regional Children's Clinical Hospital. For the first time, AD was diagnosed intraoperatively, and ID is inguinal hernia, and was diagnosed intraoperative and simultaneous hernioplasty using the PIRS technique was performed. PIRS technique, percutaneous internal ring suturing, is variant technique. It's the gold standard for laparoscopic variant of treatment children all the world, and Russian and Europe and next countries. Criterion for inclusion in this walk-in. Age from 18 years. The presence to informed consent of legal representatives for surgical invitation, and acute appendicitis and inguinal hernia. Exclusion criteria: perforation of the in the abdominal cavity. Technique of operation. We see operation boys 6 years old at acute phlegmonous appendicitis, bilateral inguinal hernia, abdominal picture, this phlegmonous appendicitis, and inguinal ring, open internal ring, internal inguinal ring, and variant of inguinal hernia, and this, and contralateral the Next, mobilization of appendix. Mobilization of appendix and closed the appendix rudder nodes, two rudder nodes. We used Lavsan suturing, and next we take PIRS for inguinal hernia. And after PIRS and acute appendicitis in cavity and retraction in cavity after procedure of PIRS. And what about patients? Left side 18%, right side 46%, bilateral 46%. And variant of appendix, catarrhal appendix 41%, gangrenol 31%, and phlegmonol 38%. This table about this picture intraoperative effusion in abdomen. Control group, this group about children with appendicitis and not inguinal hernia. And amenities in 4 children in main group. And this table about operation time, bloodless, and main syndrome after operative dates. We see in this part of slides, we see we not have statistical inclusion in this group. And the duration of the PIRS stage is 5-7 minutes for unilateral localization, 10-12 minutes for bilateral. Very, very quickly for surgery and for children. And indication. Post-operative period, minimal bloodless, average 3-5 millimeters. Post-operative period was uneventful, and the length of stay for patient with acute appendicitis and inguinal hernia was longer than for patient with acute appendicitis. Non-significant pain was observed. The children were active within the first 20 hours after appendectomy. And the children were active within the first day and 24 hours after appendectomy. There were no sign of intestinal paresis or vomiting. Stool was passed spontaneously on the third postoperative day. When examining patient after 3-6 months, Patient with complicated acute appendicitis. Children with purulent appendicular peritonitis were also been treated in 2 cases, boys age 7 and 9 years. And right side inguinal hernia was diagnosed with diffuse purulent peritonitis, and this patient underwent laparoscopy and abdominal debridement. Hernioplasty using the PIRS technique was performed 3 months later as planned. No significant adhesion were observed. The surgical 15 and 20 minutes. Conclusion. Our experience shows that simultaneous laparoscopic hernioplasty using the percutaneous deep inguinal ligation PIRS in pediatric patient undergoing surgery for acute appendicitis is tactically justified. Simultaneous intervention for acute appendicitis combined with congenital hernia do not result in significant change post-operative course. The primary criteria for surgical feasibility are the presence of appendiceal perforation and purulent abdominal effusion. Thank you for your attention, dear colleagues.
Good afternoon to everyone. First of all, I would like to thank the international community for its support of Ukraine in our resistance to Russia terror. This support means a great deal to all of us. Today, I'm joining this conference from the hospital, from a regional clinic, one of the few places where electricity and internet are guaranteed. At my workplace, power is currently unavailable as it's in many Ukrainian homes. Now we live without electricity around 14-16 hours a day. All our children are growing up outside the war. They hear and feel far more than they ever should. And this is why the topic of the children quality of life, children who are sick, who has different diseases, especially chronic or recurrent diseases, is so important today. So please allow me to proceed to my presentation. Please read and to yourself out loud. I can easily concentrate even after a sleepless night. And now, please tell honestly, do you believe in it? And what if nights like this happen 5 times? Or what if they continue for an entire month? Now please think about a child who might feel if these for months or even years. The World Health Organization established World Sleep Day to draw attention to the importance of sleep for development, health, and overall quality of life. In 2011, this day was dedicated to children's problems of children's sleep, and this year it carried the theme Prioritize Healthy Sleep. For a long time, sleep was considered merely a period of rest. However, today we know that sleep is an active physiological process that plays a crucial role and has special importance for overall functioning. In childhood, sleep has special importance as it accounts for 60-80% of daily time in infants and gradually decreases to 30% in preschoolers. And it plays a critical role in neuroplasticity, cognitive development, memory formation, and supports optimal functioning of immune and endocrine system. The causes of disturbed sleep are extremely different and include physiological factors psycho-emotional factors, and again about impact of war. 68% of adult respondents report about deterioration in health since the beginning of the war, with sleep disorders among the most common complaints. According to the analytical company Gradus Research, 75% of Ukrainian children show symptoms of psychological trauma related to the war, and every fifth child experiences significant sleep problems, frequent night awakenings, difficulty sleeping due to explosion, and stress associated with the ongoing situation. Of course, it also behavioral factors, socio-environmental factors, and medical causes. And I want to pay your attention on the last sentences where you see obstructive breathing disorder during sleep, which includes adenoid hypertrophy, enlarged tonsils, and obstructive sleep apnea. So, in the course of my scientific study, I analyzed the sleep characteristics and quality of life in 60 pediatric patients with recurrent acute respiratory viral infection associated with lymphadenoid hypertrophy of grades 1 or 2, 1, 2, and without it, and as well as in 20 somatically healthy children with isolated episodes of acute respiratory infections during the past year. So group number 1, patient with recurrent respiratory viral infection and without underlying lymphadenoid hypertrophy. Group number 2, patient with recurrent...
Hello, doctor. Sorry
Yes.
to interrupt, but can you please change your slides? The slides are not getting changed.
Now, what do you see now, please?
The first slide with your title.
Interesting. And now?
Yeah, now the slide is changed. Yeah.
Slide changed?
Yeah.
Okay. So let me please go on. And group number 3, somatically healthy children. The study included children aged from 2 to 10 years old. And the research was conducted into 2 stages. At the first stage, parents were surveyed using a questionnaire on sleep disturbances in children developed by the Ukrainian Institute of Cognitive Behavioral Therapy. On this slide, you see questions answered by parents, and among them, does the child appear sleepy during day? Does the child snore during sleep? Does the child wake up at night and feeling scared? And so on. Totally 46 questions. And when we comparing the survey result, it was found that parents reported breathing difficulties in 73.3% children of clinical group 2 versus 12 children, 40.0% children of clinical group 1. And at the same time, snoring, which indicates collapse and narrowing of the pharynx, was observed in almost 67% children with hypertrophy of the pharyngeal and palatine tonsils, and only in 6.7% frequently ill children without hypertrophy. And breathing pauses was observed in 19 children at night awakens in 30% children of group number 2, compared with 20% and 10% cases in children of group number 1. 53.3% parents in group number 2 confirmed that the child experienced night terrors or nightmares. Meanwhile, in group 1, without lymphadenoid hypertrophy, this indicator was only 5, less than 17%. Breathing disturbances during sleep, hypoxemia, and lack of restorative sleep lead to significantly more frequent daytime behavioral disorders in children of group number 2. Thus, half of the parents in this group confirmed that the child is sleepy or not well rested during the day, and almost 60% pediatric patients are aggressive, irritable, and 16 show disobedience, tantrums, or fears. At the same time, in children of group number 1, these behavioral deviations were observed in 13%, 3.3, and 16.7% cases. Polysomnographic examination was an instrumental method, what the second part of the research. So polysomnographic examination was performed in 12 children of group 1 without lymphadenoid hypertrophy and 23 children of group 2 who had sleep disturbances according to the questionnaire. Polysomnography, PSG, is the gold standard or in diagnosing sleep disorders in both adults and children, and it allows to detect sleep apnea, breathing disorders, nocturnal movement disorders, and other problems in both children and in adults. Sleep architecture, duration of sequences of stages, apnea, hypopnea index, and due to this index we can speak about severity of obstructive apnea. Obstructive sleep apnea should be in norm less than 1 per hour. Polysomnography is performed in certified laboratories, and its standards were published by the American Academy of Sleep Medicine in 2018. According to polysomnography result, mild airway obstruction was diagnosed in 2 children of group 1. In contrast, children of group 2 showed mild obstructive sleep apnea in almost 48% cases, and in 17.4% children, a moderate degree of severity was identified. PhD indicators of breathing disorders and oxygen saturation were analyzed in children of both clinical groups. More significant deviation from normal values were found in children of group 2, children with recurrent respiratory viral infection and lymphadenoid hypertrophy. This slide presents the results of polysomnography for both study groups. Please pay attention on the index apnea and hypopnea, and in both groups it is unnormal, but much more higher in group number 2, children with recurrent respiratory infection disease and lymphadenoid hypertrophy. Polysomnography in children allows distinguishing obstructive apnea from central or functional apnea, detects mild forms of sleep disorders that may manifest only as behavioral symptoms, and provides an objective assessment of treatment effectiveness, and helps avoid unnecessary surgical investigation. And small clinical case, attention, please, boy, 7 years old, family history unremarkable, allergy history non-significant findings, vaccination according to schedule, complaints, parents reported teeth grinding during sleep, bruxism, night terrors, restless sleeping, snoring during sleep, daytime sleepiness, difficulty concentrating, their son can't stay focused even on some interesting for him games, and repetitive movements, frequent blinking. And also some get sick with acute respiratory viral infection very often, about 12-14 times a year. A history of illness. Symptoms have lasted about 16 months, gradually worsening. Treated for suspected helminthic invasion and suspected ADHD without significant effect. Objective status: breathing through the mouth, voice normal, soft palate slightly swollen, palatine tonsils, hypertrophy second degree, moderately hyperemic adenoid tissue, grade 2. Laboratory test, blood test and urine test, normal. Stool for Helminth's X negative, throat microflora, Streptococcus viridans, moderate amount, no pathogenic strains. Instrumental method: nasopharyngeal endoscopy, grade 2 adenoid hypertrophy, and mucosa moderately swollen. PSG, study duration 8 hours, index apnoea-hypopnea 3.8 per hour when the norm is less than 1 per hour. Low saturation 89%, average 96. Increased number of microaerosol, aerosol index 12 per hour. And conclusion, due to PSG, mild obstructive sleep apnea. Diagnosis: obstructive sleep disorders, breathing, mild, on the background of grade 2 hypertrophy of the palatine tonsils and adenoids. Treatment: conservative treatment for 3 months, nasal irrigation with isotonic solution twice a day, short course of nasal corticosteroids under ENT supervision, and sleep hygiene. And on this slide, you can compare the indicator before treatment and after treatment. Snoring before, every night; after treatment, absent. Apnea episodes before treatment, 5-7 seconds several times a night; after, not observed. Sleep, frequent awakenings after treatment, calm, daytime attention, behavior, hyperactivity before treatment and normalization after. Bruxism, often before and not noted after. And index apnoea-hypopnea was 3.8 per hour before treatment and becomes 0.9 after treatment. Now it is in norm, because norm is less than 1 per hour. Chronic hypoxia and lack of restorative nighttime sleep impair child's psychological development. Such children may exhibit various behavioral disorders, including hyperactivity, attention difficulties, learning problems, and aggression. Studies of neurocognitive function in children who snore versus those who do not snore, that habitual snores have reduced attention, memory, learning ability, and IQ level. Sleep disturbances in children require a systematic diagnostic approach. Even mild hypertrophy of adenoids and tonsils can lead to obstructive sleep apnea. Timely diagnosis and conservative therapy can prevent surgical intervention. After sleep normalization, there is significant improvement in behavioral, attention, academic performance, and overall health. I would like to express my sincere gratitude to the organizers for this wonderful conference, webinar, and for the honor and my pleasure of being able to speak here today. I wish you all good health, strength, and inspiration. May peace prevail in our world so that our efforts, resources, hopes, and dreams can be invested in the development of education, medicine, and well-being of future generation for our children, rather than in war. Thank you very much for your attention. Glory to Ukraine.
hello also from my side. I will be representing pediatric resuscitation using ECMO from the perspective of nursing care. This is our hospital, pediatric clinic in Ljubljana, the capital city in our country, Slovenia. So ICU, whether it's a PICU or NICU, so pediatric or neonatal ICU, it's oh, sorry, so sorry. Okay, this will work. So in a case of a sudden deterioration, so worsening of a critically ill child, trained healthcare staff must respond immediately. So prompt and correct actions prevent further worsening and complications. And the most severe form of deterioration is cardiac and or respiratory arrest. So this can lead to CPR. ICU definitely is a high stress environment. Critical care is something that's done in ICU, and nurses who work in ICU must continually monitor vitals, and the key knowledge and skills that they have to have are early recognition, timely intervention, and prevention. This is our unit. We have 14 beds in our unit. So pediatric basic life support or BLS. So guidelines.
Sorry to interrupt, Doctor,
Yes?
but your slideshow is not being played, I think. The slides aren't
You
changing.
cannot. Are they not changing?
No, they're not changing.
Oh, so sorry. So you don't see this?
Yeah, now it's changed. Now the slides has changed.
Now it's changed. Okay.
Yeah.
So you can see now this picture of our unit.
Yeah.
Okay. Maybe the internet connection is a bit bad. So hopefully you can see this slide. New guidelines of ERC for resuscitation were published this year. So the principle stays the same, ABCD algorithm. So all children from 0 to 18 years in the liver treated the same. So basic BLS steps are safety, airway, breathing, all that we have to train. So simulation training definitely improves team coordination and also reduces stress in stressful situation, such as of our cases, patient in septic shock, and we had to start CPR, and later on we continued putting the child on ECMO. So the role of nursing staff in resuscitation are definitely recognition of deterioration. We are usually the first one to recognize this. We definitely have to initiate BLS if needed, activate resuscitation team, always monitor vitals, prepare medications and equipment, and we support parental presence. This was also one of our cases. The child respiratory status suddenly worsened, and we had to intubate. So ECMO as last resort in life-saving. ECMO can definitely help, but it's important to notice that it doesn't heal. So ECMO is a machine for heart and or lung support when resuscitation fails. So in high stress environment, we definitely have to have coordination of team. So ICU nurses have to be trained in BLS and ALS, and ECMO may be added for organ support in severe cases. CPR is always highly stressful, but professional training can link theory with practice for rapid, efficient, effective, and decision-making. But still, it's often chaotic and may involve blood, parents screaming, lots of things are going on, lots of people is included. So if we train enough, it can help just to organize the situation. But the most important thing is that during eCPR, so during the procedure of ECMO during resuscitation, team must also ensure the safety of other patients in the unit, because the worst case scenario that we can have is definitely that while resuscitating one child, another patient's health also worsens. So sometimes situations are something like this, and it would really help if we would have someone who would, kind of normalize the situation. This is a picture from our simulation training. Difference between ECMO and eCPR. ECMO is definitely an advanced invasive form of temporary support, where with conditions that are reversible. So this is a bridging therapy. It's not a cure. It's used for recovery, to buy time until transplantation, or any other treatment. eCPR, it's basically ECMO during CPR. It's typically via ECMO or coronary bypass. It's applied during CPR or within 20 minutes of ROST. So it supports circulation and oxygenation and minimizes ischemic injuries. This is also one of our cases. So during CPR, surgeons ECMO can. So the ECMO run was but pediatric adaptation was soon after implemented. And VV ECMO, so support for lungs, reduced neonatal mortality from 80% to 20%. So in our country, in Slovenia, in Ljubljana, we are a small volume center, and our unit, it's the only unit that can provide ECMO for pediatric or neonatal patients. Since 2009, we use flow system for survival. This year we had so far.
Hello, sorry to interrupt,
ECMO.
doctor. But again, the
Yes.
slides are not being changed.
Yes.
The slides aren't being changed.
So where is it? So you don't see moving even photos? No?
No, it's on slide number 3, I think.
Okay, I'm so sorry. So you can see anything changing or no?
Yeah, it's different from the slide that was
No.
there a minute ago.
No. Okay.
If required, I think even we can change the slides on your behalf if there's any problem with the connection.
Yeah, maybe we should try that since there are
Yeah,
so many
okay.
problems.
Okay, yeah, we'll do that.
Okay. Great, thank you. So if I repeat, ECMO is a heart and or lung machine that supports patient when resuscitation somehow fails. It requires team coordination. Lots of things are going on during that. So ICU nurses have to be trained in BLS, so basic life support and advanced life support. But we have to always remember that ECMO can be added for support, for organ support, but it doesn't cure anything. CPR is always highly stressful. So we have to train because professional training links theory with practice, and we can definitely ensure rapid and effective decision making. So CPR is often chaotic and may involve blood, patient screaming, parents screaming, it's quite stressful. Nevertheless, you may train many times. but we have to always ensure safety for other patients on the unit, because the last thing that we want is deterioration with another patient. So we can, if you can change. Thank you. So some pictures of what we don't want to happen, and it would be useful if we would have a person that would just calm the situation down. Okay. This was during our simulation training in our center. So as said before, ECMO is an advanced invasive form of temporary support where reversible events can happen. It's a bridging therapy, it's not a cure. So it's used to buy time until recovery or transplantation or any further treatment. ECPR is simply ECMO that is done during CPR. It's either during chest compressions or within 20 minutes of ROS. Okay. This was our one of our cases. So patient was in septic shock, but the main problem was that this patient previously already had 2 ECMO runs. So this would be her 3rd ECMO run. So in history, in 1960s, there was first ECMO run with adults, but in pediatric field, the adaptation of ECMO followed soon after. It did, the use of ECMO, it did reduce neonatal mortality from 18 to 20%, which is quite an improvement. In our unit, we are the only unit in our country that can provide pediatric or neonatal ECMO runs, but we are still small volume center since the whole population of our country is 2 million people. You can see that our numbers are really quite low. So far this year, we had 4 ECMO runs with 1 ECPR. Okay. This was our previous ECMO machine. Okay. This is a patient after cardiac surgery on ECMO. So nursing role in ECMO, it's definitely to assist in BLS and ALS. We have to prepare, assemble, and prime and calibrate ECMO circuit. We monitor flow, oxygenator, and hemodynamics. We administer meds and blood products when needed. We maintain sterility, connect to power or gases, and monitor patient. We have to do blood sampling, documentation, and support families. In our unit, we ensure ECMO readiness and team coordination, and every single day we have 1 nurse who is on call just in case of ECMO run. Okay. So this is during training in priming ECMO. This was during, I don't know, around 3 a.m. in the morning when we had ECMO run. So it's also important to think about post-resuscitation nursing role. We have to prevent secondary organ injury, especially brain, heart, and lungs also. We monitor vitals. We have to ensure temperature control. We also provide feedings. We have to be aware of urinary output, of bowel care, and again, we are the first one usually who detects the deviations and optimize recovery. So also in rehabilitation or long-term outcomes, we have to make sure to provide physical, cognitive, and emotional support. We support the whole families. Functional and cognitive assessments before discharge have to be done. And early rehabilitation definitely improves quality of life. So for conclusion, central role of nurses in ICU, they're definitely key element in ICU healthcare. We ensure early recognition, timely intervention, and coordination of the whole team. We optimize care and reduce neurological risk. So we can just say that skilled nursing care improves outcomes and survival. Nurses are central to successful ECMO outcomes because of their clinical and physiological aspects of care. So sorry for troubles with presentation, but that would be it from my side.
Hello everyone, my name is Mariam Saleem and I'm going to be presenting the very important topic, IgA vasculitis in a 7-year-old female child with recurrent respiratory infections. Thank you guys for having me at this Pediatrics Congress conference in Paris. I'm very sorry that I couldn't make it in person, but I'm excited to be able to give you guys this presentation virtually. So thank you. So this slide is just going to go over the abstract, but we're going to get into all this information later inside the PowerPoint. So we'll go ahead and skip it. So to begin, we're going to talk about the incidence of IgA vasculitis. As we all know, IgA vasculitis is a pretty rare disease. It has an incidence rate of 3 to 27 per 100,000 individuals, and it really affects the pediatric population. So we all want to be very understanding of the clinical manifestations as well as any adverse effects that could affect our pediatric population from this disease and be able to really catch it when it comes in. So what would we keep in mind? Well, we need to know again that IgA vasculitis usually follows an upper respiratory tract infection, and in all reality, it's just shows up as palpable purpura, arthritis, arthralgia, abdominal pain, and you could see kidney involvement. So it's important to make sure you get a urinalysis in order to see if there's any hematuria as a manifestation inside your pediatric patient. But the pathophysiology at the end of the day is the patient got a upper respiratory tract infection, and now the immune response is doing a super exaggerated response, leading to systemic inflammation in the patient, and that way we see these clinical manifestations further down the line. The pathophysiology is thought to involve IgA deposition within the vessels of the alveolar septa, and that causes dysfunction in the alveolar capillary membrane, which is why we could, in some cases, see some diffuse alveolar hemorrhage. It's very rare to see that, but it can manifest inside the pulmonary system as well. So the case that I saw in clinic, I saw a 7-year-old female with a history of recurrent respiratory infections, and that was likely linked to her premature birth at 27 weeks gestation. Prematurity, particularly birth before 32 weeks, it is associated with a higher risk of long-term respiratory morbidity, potentially contributing to her recurrent infections, which is what she suffered from multiple times before. Compared to a term birth before 32 weeks gestation carries a twofold risk for a long-term respiratory morbidity, whereas birth at moderate to late preterm, 32 to 36 weeks, carries a 1.3-fold risk for long-term respiratory morbidity. So our case, it highlights the clinical manifestation, diagnostic considerations, and management strategies for IgA vasculitis while exploring the potential relationship between premature birth and susceptibility to this condition. So let's get into the case study. So our 7-year-old patient, she came into clinic and she complained of purpuric rash and painful joints. Her mother reported that 2 days prior, the child was treated for streptococcal pharyngitis with amoxicillin following symptoms of fever, throat pain, and vomiting. However, the patient developed a rash within 24 hours of starting the antibiotic. The mother presumed that these were insect bites, which progressively worsened in size and severity. But as you'll see later, when I show the images that I took of the patient, it doesn't look like any sort of insect bite could have caused that. It's very obviously a vasculitis and palpable purpura from the vasculitis. The patient also experienced pruritus and reported difficulty walking due to the joint pain. The patient's medical history was notable for prematurity at 27 weeks gestation, recurrent respiratory infections, including the pneumonia and streptococcal pharyngitis, as well as asthma. Recurrent medications included amoxicillin, Advair, albuterol, cetirizine, fluticasone, and montelukast. On physical exam, the patient was visibly distressed, tearful, and in pain. Her vital signs really, what we'll note here is the mild tachycardia, which was something to keep in mind for later. On physical exam, the patient had erythematous and edematous purpuric lesions on both the upper and the lower extremities, which I'll show in the figure in the next slide. And that was accompanied by periarticular swelling and tenderness in the knees and the ankles. The ankles were the most significant on physical exam, and the patient was refusing to walk because of the pain. The rest of the physical exam was unremarkable, with clear lung fields, normal cardiac sounds, and no abdominal tenderness at the time. Laboratory findings were significant for hematuria on urinalysis, which is why it's very important in order to do a full workup just to get a UA to see how badly it manifests in other organ systems. So you can see here in the image, you can see the lower extremities with purpuric and swollen joints down here a little bit. It'll show better in the other images, but you can see how the vasculitis is manifesting in the skin with these lesions right here. You can also see inside this image the palpable purpura as well as there's a little bit of raising because of the itchiness of the purpura, and the joints were causing her a lot of pain. So she was having really bad arthralgia in this image as well. But it was the manifestation in the lower extremities were very evident. This is what it looked like in her left upper extremity, and I think this is probably the best image we have of how we have the purpura. So this is clearly not any kind of urticaria or anything of that manifestation. You can see how this is clearly a vasculitis induced because the blood vessels are allowing this manifestation to show in the upper extremity. So our differential diagnosis had to include multiple things because, again, medicine, even though you have something at the top of your diagnosis differential list, you need to rule out other causes. So we had IgA vasculitis as our number one, acute urticaria, just because of the mother and the itching that were manifesting in this patient. Acute glomerulonephritis, again, we got that urinalysis, which clearly showed hematuria, and idiopathic thrombocytopenic purpura. So given the patient's respiratory infections, her antibiotic regimen was switched from amoxicillin to azithromycin, and corticosteroid therapy with prednisolone was initiated, which is very important for treating any patient that is having any vasculitis. We did have a follow-up visit, was scheduled 2 days later with instructions to monitor for hematuria and the abdominal pain. So upon returning for follow-up at the office 2 days later, the patient's mother reported worsening symptoms, including nausea, vomiting, fatigue, and new purpuric lesions behind the ear, which you can see in this image right here, and on the face and on the thighs. The child also lost 5 pounds since the previous visit due to new symptom of abdominal pain. Despite these concerning developments, there were no changes in urine or stool color. The repeat physical exam confirmed the spread of the rash, although its character remained unchanged. Given the deterioration, hospital admission for close monitoring and further treatment was strongly recommended. However, the patient's mother declined hospitalization, opting instead for care at a more distant children's hospital. So she took her daughter a little bit further out um, because she had more family nearby at the separate hospital. So our discussion. So IgA vasculitis, formerly known as Henoch-Schönlein Purpura, frequently follows a viral or bacterial infection, as we saw in this patient, and most commonly it's group A strep infections. The underlying mechanism involves exaggerated immune response that triggers a systemic vasculitis, particularly affecting the small vessels. Although the precise pathogenesis remains unclear, it is widely believed that immune complex deposition plays a central role in the disease development. So, Glenn, as clinicians, we need to understand the triad of symptoms, which is everything we saw in this patient: the purpura, the arthritis and arthralgia, the abdominal pain, and renal involvement. Again, is really common complication and it's something that we're going to have to monitor in the future. So, get a urinalysis. Early recognition is critical as severe complications such as nephritis, intussusception, which is why that abdominal pain prompted us to tell the patient and her mother to go ahead and go to the hospital because this is a very bad complication of um, IgA vasculitis, as well as any GI hemorrhage can arise without timely intervention. So it's better to have close monitoring in inpatient setting. So the important considerations, the potential link between premature birth and heightened susceptibility to IgA vasculitis, it warrants further investigation. These 3 points are really important to this presentation. Prematurity is associated with long-term respiratory and immune challenges, which may predispose individuals to exaggerated immune responses later in life, which means any premature patient that you might have, you might want to keep this on the differential if they present with these kinds of clinical symptoms. The potential respiratory manifestations raise alarm for the occurrence of the disease in those with prior existing pulmonary dysfunction, and recurrent streptococcal infections may play a role in increasing the risk of developing IgA vasculitis. Although IgA vasculitis is known to be frequently following streptococcal infections, The impact of recurrent infections on disease severity and recurrence is not well understood and deserves further exploration. So as I've emphasized mostly inside this presentation is the need to get a urinalysis, because the most pressing aspect of this presentation, again, is to continue to monitor renal function and possibly get a nephrology consultation. The patient presented to the clinic with hematuria, and therefore a dose of oral steroids was prescribed. The patient did not return to the clinic and went to an out-of-network hospital due to the inability to ambulate and further progression of the disease. It is likely that during her hospital stay, she was administered high-dose IV steroids, as they are often used and are successful in the treatment of glomerulonephritis and severe renal involvement. The kidney is arguably the most serious organ involved in IgA vasculitis. In 2013, there was a double-blind randomized trial was performed that compared corticosteroids with placebo. The study showed no benefit in reducing proteinuria, but again, we were treating the hematuria 12 months after disease onset. The pathophysiology behind kidney involvement is the deposition of IgA in the mesangium of the glomeruli, where blood filtration occurs, causing kidney manifestations such as hematuria. This may lead to long-term kidney damage, and therefore monitoring the kidney function in follow-up visits is very, very important. So the limitation of this study is the lack of follow-up after the patient's transferred to another hospital, as mentioned above, but that was just at the time that this paper was written. The patient actually did come back to clinic about a month later, and she had a full recovery, so she's doing much better now. But nonetheless, at the time, the case emphasized the need for prompt recognition, management of IgA vasculitis, particularly in pediatric patients with complex medical histories, as seen in this patient. So, in conclusion, IgA vasculitis is a rare disease that affects the pediatric population. The classic presentation includes palpable purpura, the arthritis and arthralgia, abdominal pain, and kidney involvement. The case presented illustrates a classic case of IgA vasculitis in a patient whose past medical history may provide the insight into the pathophysiology of the disease itself. This case highlights the importance of early diagnosis and management of IgA vasculitis, particularly in pediatric patients and with underlying comorbidities such as prematurity and recurrent respiratory infections. Timely intervention can prevent serious complications, including renal failure, significant GI bleeding, and extensive edema. This case offers potential areas for further exploration. Further research should explore the potential link between premature birth and developing IgA vasculitis, as well as the role of recurrent infections in disease progression. And this is my references, and thank you guys so much for having me.
Yeah, good evening, everyone. My name is Dr. Jerry Nyamugabo. I'm from DRC, and currently I'm at Guinea Medical University in the Department of General Medicine. And I'd like to present to you guys is a case report. The case report of a 4-year-old man child bilateral nephroblastoma. So why this is important, our content? We will overview case study and discussion, conclusion, some recommendation. Like you know that nephroblastoma is one of the embryologic tumor that's developed in early life. It's so particular in growing up. So why this is interesting? Because of the circumstance and the lack of we don't have accessibility to good diagnosis and to diagnose earlier some cancers, especially in our condition. Third world country, we don't have all necessity to diagnosis, and the management and the treatments depend on the good diagnosis. So most of cancer, you cannot get a good diagnosis because you don't have a lot of facility, a lot of technique going through diagnosis. Like I said in the beginning, we received this young boy. I was in emergency that day, and he complained about abdominal mass. That was the chief complaint. And when we received, we do clinical evaluation, and everything was plead in favor of a tumor in abdomen tumor. So the patient complained about pain, cough, and fever, and we have hematuria, high blood pressure, and loose appetite, nausea, and vomiting. But we tried to do our best. Some biological assessment, we showed that the patient was, he showed us a sign of infection. That's because the patient came from infection syndrome. That was the chief complaint and diagnosis when admitted in pediatric emergency. But when we did now, we sent the boy to the margin and they perform ultrasound, review some image in favor of the mass. That mass in favor in one of the tumor. So we can't just stop there because in our situation we cannot do CT scan, and IRM we cannot do it because it's not available. Patient cannot afford it, and also our situation, if you want to ask this kind of imaging, is so expensive, and some of the patients they don't have resources. Like DRC and this part of the that country is occupied by some situation of the war and those things. So some patients they cannot afford it. Imagine some patients they cannot afford food and those things. So you tell them to do CT scan. Is one of the exam so expensive in our region, and they cannot afford it. So we did just ultrasound to just guide us, and also at least we did also chest X-ray to combine and to identify, because when the patient complained about a cough, so we did just to combine and to make some differential diagnosis, because we suspect some metastasis of that tumor. So like we said, the ultrasound shows the image of the kidney, and he played in favor of nephroblastoma lesion. We have the measuring of 15 millimeter of the left and 3 on the right side. So all of these things will help us now to think a lot about why we can proceed without to get something. So the followings help us to identify, to ask ourselves question, how this boy can get a good treatment and how to prevent all of those things, because some patients is not, we like a professional, we know like we work in third hot country. That means we don't have a lot of resources. We don't have a lot of facility to perform, even if some protocol is applied, because we don't have resources. We use what we have. So when through surgery is just to confirm and to apply the surgery, and we discover that it was both sides. It's not just one kidney, but both sides. Bilateral nephroblastoma, and we did biopsy. We sent the sample to evaluate another deep evaluation, anatomy pathology evaluation, and they confirmed the diagnosis. So in our side, we cannot do nothing because we know the protocol. When the patient discovered this, it was too late. Imagine 4-year-old, and according to the history of the sickness, the patient had since 2 years, though the mom noticed this tumor. But our circumstances and our culture, for them, they thought that it was just normal process. It's some tumor, or it could disappear later. This mass is not treat them. So when the young boy came with that infectious disease, we did some investigation and found that it's not normal. That's why we took ourselves, and this both side of the kidney does trick us again. because most of nephroblastoma is not just, some of them is just, it can be one side, and the classification of the both side is not just the parenchyma, but the all and adrenal gland was also attend to the same tumor. So we did what our surgeon did. They did subtotal nephrectomia. That was this nephrectomia of 6 centimeters of the all entire kidney millimeter, sorry. And the right one, it was just the palliative and resective surgery, because we cannot do nothing. At the point, we don't have accessibility to chemotherapy or radiotherapy, and the patients, they cannot afford it. It's expensive. And also, in our condition, when the patients came, they don't have resources, they don't have any insurance who can help them to go through this thing. So we discuss what we discover. It's cover like most of kidney tumor, 5 and 6% of of juvenile malignity of some tumor, predominantly children under 6 years old. And in our cases, the boy was 4 years old. So it's confirmed that 5 and 8% of all of the tumor, they went through malignity. So that means we too, like we can see in the beginning, I said that we discover some metastasis in their lung, and around the abdomen we have a lot of metastasis in the same, to confirm the same one. So most of more than 4 and 80% of cases, like some authors say, that they have bilateral mesoblastoma account from 4 to 8% in some cases. And this one confirmed that many of these neuroblastoma, they have metastasis in 1 or 2 cases. Some of them that just unique, or just one parenchyma of, it can be left or right of the kidney. So we applied, like you see, we perform nephrectomia in just one of the pieces. For us, it's not curative care. We did just palliative care because we cannot do nothing. Like, the protocol is first, we can start the surgery, perform the surgery. But in this now, we just do the surgery to just, one placebo, because that we cannot tell the patient that you cannot do nothing, and they cannot afford it. Even if the government, they don't have program for the cancer in this situation in our region, and how to diagnose earlier. So all of these things help us recognize that the most of the things, many patients spend in material and those things like we have in our cases, all of the clinic, most of the patients, they have the same clinic. And the first option in third world country is ultrasound and X-rays. That is the basics and what we can do, because it's the one we can afford in our cases. CT scan and all of the other one, imagine, can show us with precision the tumor in that stage. We cannot perform it because we don't have accessibility and the resources to get that result. So, and at least we can perform, and we can do biopsy and to get some analysis of tissue that is can confirm if it's the cancer or not. But in our situation, no matter, we discover late if it's the cancer or not. But the other place, they can do and they can predict some cancer in the earlier age, and they start the therapy. So all of this is just to tell you guys that we have a lot of problem in our region, because a lot of patients die. It's not that we don't have professional, we don't have people that can perform or they can get diagnosis, but we don't have resources. Imagine the boy came, the management is required a lot of things, like we have a lot of discipline, multidisciplinary consultative meeting, we make the phenotherapy decision. That's it. When we work in the team, pediatrician, we work with surgeon, we work with radiologists, and all of them like a team. And also we have some pathologists to work together. But in our situation, you can see some hospitals, they don't have pathologists, they don't have radiologists, they don't have some pediatric, they don't have people qualified to just first stage to get diagnosis. So it still faces a lot of problems. It's not just shortage of human resources, but also we don't have equipment, we don't have anything because of what government they cannot support, and hospital we work just to find diagnosis. We can have suspicion of diagnosis, but we are always limited to get their resources. So the aim of this is it was just to boost ourselves, and if we can get some protocol how to diagnose earlier in our condition, like third world country, how we can predict some cancer, to have a protocol to predict some cancer, because in our situation, we are limited. We can perform a lot. We cannot perform a lot of procedure because of we don't have resources, we don't have support, we don't have, and patients also, they don't have resources, they don't have also insurance to take care of those cancers. So how we professional we can think about how we can predict to just at least make a good diagnosis earlier. Because if you make a good diagnosis earlier, like the case of this young boy, he came late to hospital because of what? The patients, the parents, they don't know how to get this diagnosis. That's the first one. The second one, the professional. Is he the midwife who attends the mom in the lab, in the maternity, and those things? They don't know about all of this. How can do this assignment from the childhood, the first day, neonatology care, all of those things? How we can predict some diagnosis and to not just treat the consequence of something we can predict before. We know ourselves our limitation. We know ourselves what is our limitation and what we can do to get a good diagnosis. Because the treatment depends on good diagnosis, and we know all that third world country, we already have the problem of how to get a good diagnosis. Sometimes we say we don't have cancer because of what? We cannot diagnose those cancer. Is it the government to help us? Is it the national, international organization can help us, or no government organization can help us? Or is all healthcare professional to be aware about how is crucial these things, how we need to invest ourselves, a good diagnosis. If you receive the patients, make sure we do the all medical assessment from the beginning and ask the good question to the parents, so that it will help us to avoid such as cases in the future. But we know that we don't have resources to handle such as cases, and many patients will die. Not that because they don't know, but professional. We are not push ourselves to improve and to get the good care. Thank you so much. Is what I just did in this abstract. Thank you so much.